안녕하세요. 마스터 코스를 진행하고 있는 K치과 강춘규 원장입니다.
Greetings, I'm Dr. Kang Chun-gyu of K Dental Clinic and I am providing master course. Today I'm going to talk about immediate implant placement. In a nutshell, we try to do immediate implant placement after extraction. The reason being it reduces treatment time and it is a one-stage surgery, so patients really like it. If possible, immediate implant placement is attempted, but this cannot be done for all cases. So we're going to look at when it can be applied and what kind of considerations that we need to make. Let's look at the contents. First is implant placement period after extraction, classification of different periods, and factors that determine the placement period. Second is the necessity of immediate placement, as well as indications and contraindications. Third is the challenges that needs to be addressed in immediate implant placement. If possible, atraumatic extraction should be done, inflammation control, appropriate primary stability, appropriate GBR, inbound defect, soft tissue gap management should be performed, and appropriate provisional needs to be provided in the anterior area. Thereafter, I'm going to talk about some cases. Let's talk about implant placement after extraction. Depending on the period, there's immediate implant placement. This is placing implant within 1 week after extraction. As for early placement, it is placing implant between 2nd and 8th week after extraction. This means that there's a localized inflammation in this case. Third is delayed placement, where implant is placed between 2 months and 4 months later. The extraction socket is healed with soft tissue and implant is placed with somewhat bone formation. If you look at immediate implant placement case, this is root caries. Because of it, extraction was done. This is a immediate implant placement indication. After extraction, implant was placed and healing was done nicely and prosthesis was delivered. If possible, immediate implant placement can be done and provide clinically safe long-term results. This is before extraction. This is before GBR, after GBR, and after prosthesis delivery. You do not need to stick to delayed implant placement. You can get good results using this methodology. Next is early placement. From 2 weeks to 8 weeks after extraction. It is easy to address the soft tissue and the localized lesion can be healed. The downside is that because of the changes in extraction socket, it can be difficult to place the implant in ideal position. Additional surgery may be needed, and depending on the technique of the surgeon, the results may vary. The extraction socket can be resorbed in a lot of ways. In the anterior area, such resorption could be worse. Let's look at a case. After 3 weeks since extraction, implant was to be placed. This is before implant placement. This is clinical photo. And right after this, extraction was done. And 3 weeks later, implant was placed. As you can see, the extraction socket is still like this. Implant was placed and in this gap area, GBR was done. Membrane was used. 2-stage surgery was done and secondary surgery was done 2 months later. You can see bone healing here. After secondary surgery, final prosthesis was delivered. If you use appropriate GBR, you can get stable results in early placement cases as well. The final one is delayed placement. This is implant placement after 2 months since extraction. There are less factors to consider in implant placement, and it is very easy to manage the soft tissue. The downside is that as we wait for healing, the treatment period becomes elongated and additional procedures may be required because of increased bone loss. The extraction socket wall can be resorbed and the amount of available bone may vary. As you can see, extraction was done. There was no bone below. Therefore, immediate implant placement could not be done. We decided to wait. Delayed placement was done. If you can see here, this is 3 months after extraction. You can see bone formation here and soft tissue has fully healed. It was very easy to manage soft tissue. Implant was placed and prosthesis was delivered. This is delayed placement. Let's look at benefits and downside of immediate implant placement. There are many advantages from prosthodontic perspective because there is a very little bone loss. Implant can be placed in ideal position. The biggest advantage is that treatment period is reduced and it is a one-stage surgery, so patients really like it and it's good for surgeons as well. Another advantage is that by using the healing potential of the extraction socket, healing can occur more nicely. With appropriate GB or bone structures maintained, an ideal soft tissue can be maintained, especially in the anterior zone. The lamellar bone, which is very thin, it becomes resorbed and soft tissue can be resorbed along with that, but by doing immediate implant placement, the soft tissue can be maintained. This is a major benefit of immediate implant placement. In my case, in anterior cases, over 90% of the time, I try to do immediate implant placement. The biggest reason is to maintain ideal soft tissue. That is why I tend to do immediate implant placement. The downside is, in the case of thin biotype, the surgery result may not be favorable. If there's no keratinized tissue, the healing may be difficult depending on the surgeon's capability. The results may vary. It is technique sensitive. As you can see here in number 11, this is before immediate implant placement. Through immediate implant placement, prosthesis was delivered here. 10 years later, you can see that by using appropriate amount of GBR and factors, the prosthesis is maintained nicely here. As shown, if you can get good results long term, there is no reason not to use immediate implant placement. In determining when to place the implant, there are factors that need to be considered when we determine the placement time. The amount of alveolar bone below the root. If there's available bone, you can do immediate implant placement. If there isn't, you can't do it. You need to also check whether there's acute inflammation. Also, the quality and quantity of soft tissue needs to be evaluated, and this also affects the implant placement period. First, the amount of alveolar bone below the root. This is to get stable primary stability. There's only limited amount of lateral bone contact, therefore we need to get primary stability from the inferior bone. The amount of residual alveolar bone needs to be evaluated. It needs to be at least over 3 millimeters. As you can see below, if there is sufficient amount of alveolar bone, this can be considered indication for immediate implant placement. Second is whether there's inflammation. Chronic inflammation does not matter, but if there is acute inflammation or if there is suppuration, we cannot place implant As we control this, we need to evaluate whether there's acute inflammation and how extensive it is. Third is the amount of soft tissue and the quality of it. If there's no soft tissue atrophy and if there's over 2 millimeter of keratinized tissue, it'll be good, but if such criteria cannot be met, delayed implant placement should be considered more so than thin biotype. Thick biotype would be considered indication. If there's sufficient keratinized tissue, then it would be indication for immediate implant placement. As you can see, if there's a severe soft tissue atrophy, if you do immediate implant placement, unaesthetic results can be. Therefore, we need to wait after extraction. In the case of thin biotype, it is better to do delayed placement. In the case of thin biotype, if you put in the probe, you can see through. That can be considered as thin biotype. I've talked about the indications for immediate implant placement. First, there needs to be residual bone where we can get primary stability. It needs to be over 3 millimeters. Also, there should not be any suppuration or acute inflammation. Another point I would like to mention is that the position of the tooth that is in question, we need to evaluate whether it is okay for prosthesis delivery. Now the contraindications. Below the extraction socket, if there's no residual bone of over 3 millimeter and if there's active infection, this is contraindication for immediate implant placement as shown. There's an extensive gingival atrophy on the buccal side and the aesthetics are unfavorable. Therefore, delayed placement should be done. And if the position of the tooth to be extracted is unfavorable and if prosthesis is not likely here, immediate implant placement cannot be done. As shown here, below the tooth, there's no bone where we can get stability. It's sinus here, and after extraction socket, if there's mandibular canal, there's no bone to get stability, and therefore it's contraindication for immediate implant placement. On the buccal side, there's a lot of gingival atrophy. If you make prosthesis, then unaesthetic results can be. In this case, you need to wait after extraction and do implant placement. After extraction, I waited for about 5 months. When implant was placed as shown, in this area, gingival atrophy occurred and bone resorption occurred like this. Implant was placed and on the exposed area on the buccal side, appropriate GBR was done. Resorbable membrane was covered and 2-stage surgery was done. 4 months later, secondary surgery was performed. As shown here on the buccal side, new bone was formed. Abutment was connected and a temporary provisional was fabricated and suture was done. This is the image of provisional and this is the image of final prosthesis. This is before extraction and this is after extraction. This is final prosthesis. Compared with the before extraction, aesthetic restorations were provided to the patient. As shown, on the buccal side, there was excessive gingival atrophy. Delayed implant placement should be done to gain aesthetic results. Let's look at a study on the success of immediate implant placement. Sirov et al. Announced it in 2003. It compared immediate versus delayed placement and looked at bone healing. The success rate does not differ bone regeneration rate was higher in immediate placement. What is important here is that bone regeneration occurred more in 3-wall defect. This means that if possible, as shown, by placing the implant more lingual and palatally, you can make a 3-wall defect. This will lead to better results. If it is placed too buccally, then it will be a 1-wall defect. Then, clinically, we will not be able to get good results. Therefore, in the case of immediate implant placement, you need to place it towards the lingual and palatal area to make sufficient gap here and do GBR so that buccal bone can be formed nicely. This study really highlighted that point. Next, these are the challenges related to immediate implant placement. As mentioned, a traumatic extraction should be done. We need to preserve the existing bone. And if you damage soft tissue, unaesthetic results can come to be. Therefore, a traumatic extraction needs to be done. All extraction cases have a little bit of inflammation. Therefore, thorough inflammation control is very important. In the case of immediate implant placement, because there's no lateral wall, in order to get sufficient primary stability, you need to pay a lot of attention to that. As mentioned, in bone defect, appropriate GBR is necessary for success. You also need to manage soft tissue gap, and appropriate provisional needs to be provided in the anterior case. Specific details will be shared in offline course. Let me close my lecture by sharing a couple of cases. This was a 50-year-old female patient, and because of root fracture in the anterior area, extraction was done. If possible, I prefer immediate implant placement in the anterior area. This is before extraction. There's a little bit of inflammation, but it was not active inflammation and it was not suppurative inflammation. Inflammation control was done and immediate implant placement was planned. After extraction, laser was used. Ozonatron was used to control the inflammation, and as mentioned, I placed the implant slightly towards the lingual side so that the gap can be formed on the buccal side. A GBR was done. In order to provide a provisional, rigid abutment was connected and GBR was done. I used autogenous and xenograft for GBR and suture was done. Provisional was provided. As shown, when you make a provisional in CO site, the freedom should be at least 0.5 to 2 millimeters so that the implant does not fail due to unwanted lateral force. This is after surgery. You can see that soft tissue healing has occurred nicely. And this is after prosthesis delivery. Compared with before extraction, this is after surgery and prosthesis delivery. Compared with before extraction, the prosthesis looks unchanged and it is quite ideal. The results are very good. This is after prosthesis and this is after 4 years and 7 years since prosthesis delivery. You can see that stable results have been achieved, although significant period has elapsed. If you look at the X-ray, this is before extraction, before GBR, and after GBR and abutment connection. The next one is after final abutment connection. This is 1 year after, 4 years after, and 7 years after. There's no marginal bone loss, and on the buccal side, there's bone healing and it's maintained. On the anterior area, if you choose appropriate position and do GBR, even with significant time, stable results can be achieved with implant prosthesis. This is a second case. Endodontic treatment was done and crown was delivered, but symptoms continued. Re-endodontic treatment was provided in the end on the mesial side. Because of root fracture, extraction was done. This is after extraction. In the area for implant placement, there's interseptal bone. This is where we're going to get primary stability. This is going to be the center of implanted prosthesis, so therefore, I tried to place the implant here. I positioned it and I checked the position and evaluated using parallel pin. Implant was placed. It was slightly placed lingually and gap was formed on the buccal side. GBR was done. In order to manage soft tissue gap, a resorbable membrane was used and healing abutment was connected. Non-submerged GBR was done. This is after healing and prosthesis was delivered. Before extraction, after extraction, and the position was checked using parallel pin. Before GBR, after GBR, and the healing abutment is connected. This is after prosthesis delivery 1 year later and 2 years later. You can see the prosthesis is maintained nicely. Up until now, I've talked about when immediate implant placement should be done, and also I've talked about the benefits and considerations that need to be made. We need to choose the right indication and evaluate different factors. And then proceed with immediate implant placement. You can get the stable results even with a significant time. Aesthetic results can be maintained long term. Now I will end my lecture on immediate implant placement and considerations thereof. Thank you.